The following is a presentation on the prevention of mother-to-child transmission of HIV, hereafter known as PMTCT, program in the country of Thailand. Background: HIV, or human immunodeficiency virus, is a retrovirus that is transmitted through various bodily fluids, primarily blood, semen, vaginal fluids, and breast milk. Once transmitted, the virus attacks the body's CD4 cells, or T cells, an important part of the immune system. When left untreated, the number of CD4 cells continues to decline, resulting in the condition known as AIDS, acquired immune deficiency syndrome. AIDS is typically not a cause of death, but a precursor to it, with most succumbing to various infections or cancers, such as tuberculosis or pneumonia. There is currently no cure for the disease, but antiretroviral medications, first developed in the 1990s, have made the disease a chronic condition, prolonging life by lowering viral loads and allowing CD4 cell counts to stay elevated. Access to these important medications has been a central component of supply management chains and pharmaceutical procurement for the last 2 decades. Since being identified in the 1980s, the condition known as HIV/AIDS has become one of the largest-scale epidemics in history. As of 2013, approximately 35 million people are currently living with HIV/AIDS. Though antiretroviral medications have greatly helped decrease the number of deaths per year, the number still remains high, with 1.5 million people dying from AIDS in 2013, and over 39 million dying since the disease was recognized. Specifically in the country of Thailand, after an initial spike in cases in the early 1990s, largely due to improved access to testing, the numbers of infected and new infections have both been steadily dropping. More recently, these numbers have begun to plateau, which will be discussed at a later point in this presentation. The table seen on the right is a demonstration of these numbers, while the picture on the left demonstrates which WHO regions have been most affected by the HIV/AIDS epidemic. Thailand, found in the Southeast Asian region, is part of a region with approximately 3.4 million current cases of HIV/AIDS. As stated previously, despite decreasing numbers of infections of HIV/AIDS in Thailand, the rates of decline have begun to plateau overall. This can largely be attributed to the HIV prevalence remaining high in certain key populations. You are at risk for HIV by any of the means listed in this pictogram, but the greatest risk in the country of Thailand, currently, comes from either unprotected sex or injecting drugs, which are indicated by the gray and yellow arrows. 90% of all new HIV infections in Thailand are due to unprotected sex. Of these, 41% are among men who have sex with men, male sex workers, and transgender people. 12% of new infections are in female sex workers and their clients. The HIV prevalence in male sex workers between 2009 and 2013 was 12%. Looking at all this information, it is thus important to realize that new targets concerning lessening the HIV/AIDS epidemic in Thailand must work to contact with these key groups. Another key group at risk for HIV/AIDS in Thailand is injection drug users. It is estimated that there are 30,000 injection drug users in Thailand. The HIV prevalence among this population is 29.7% in females and 24.5% in males. Efforts in Thailand to help these key groups are ongoing. A previously high rate of vertical transmission of HIV from mother to child has been lowered due to the effective PMTCT program in place in the country, the focus of this presentation. PMTCT is important for the elimination of HIV/AIDS from mothers, infants, and the entire global population. PMTCT is valuable for mothers as it allows the mother to take ARVs during pregnancy. The viral load is kept low, and the progression of the disease to AIDS is stalled, extending her life. PMTCT is important for infants as it largely stymies vertical transmission of the virus. Currently, 90% of new HIV infections among infants and young children occur through mother-to-child transmission. Without PMTCT, the risk of transmission of infection from mother to child is between 20 and 45%. With a full PMTCT program involving the distribution of pharmaceuticals and complementary HIV testing, counseling, and support, this transmission rate can be reduced to less than 2%. Finally, PMTCT is beneficial for the entire global population, as it decreases the overall number of new infections in children and in adults, as antiretroviral medications can serve a preventive purpose as well. There are unfortunately still barriers in place to accessing and rationally using PMTCT. These include improper knowledge of HIV, mother-to-child transmission and PMTCT, lacking knowledge of your HIV status, confusion over exclusive breastfeeding, as different programs have different policies, HIV stigma and discrimination, poor services, a lack of proper monitoring of health systems and programs, a lack of privacy at healthcare sites, a propensity for male-dominated decision-making, antiretrovirals not being available in the local area or being too expensive, transportation to healthcare sites being too expensive or of poor quality, healthcare worker shortages, unacceptable or expired antiretrovirals, and a lack of proper training for healthcare workers who distribute medications. This is not an exhaustive list, and other barriers to access continue to exist along the supply management chain. The first evidence of success of PMTCT occurred in 1994, when a pediatric AIDS clinical trials group, number 076, found there was a 67% reduction in perinatal HIV transmission when mothers were provided with the antiretroviral zidovudine, ZDV, prenatally, during labor, and to infants after birth. The first trials for PMTCT in Thailand began to occur in 1995. A trial of short-course ZDV to mothers in 2 Bangkok hospitals between 1995 and 1998 found that MTCT was reduced from 18.9 to 9.4%. Another randomized trial of both short and long-course ZDV between 1997 and 1999 found transmission rates had decreased to 4.7 to 8.6%, much improved from initial rates of transmission without ARVs. Because of this evidence, an official national PMTCT program was begun in Thailand in 2000. These initial trials of PMTCT in Thailand were largely successful because of a high uptake of antenatal HIV testing, the availability of ZDB prophylaxis, and a high degree of support from both the regional and national Thai ministries of health. In comparison, countries of similar or lesser economic profiles to Thailand have been less successful with PMTCT programs. This is often due to a lack of access to ARVs. As of 2008, 40% of countries still see less than 25% total coverage of HIV-positive mothers with ARVs. Now, we will begin to look at Thailand's current PMTCT program. The National PMTCT program was begun by the Thai Ministry of Public Health in 2000. This initial program included services for HIV-infected pregnant women and their newborns, including antiretroviral therapy, a CD4 cell count test for mothers, necessary for determining what ARVs the mother was offered, an infant HIV test, and infant formula for 18 months. This was accompanied by counseling regarding the use of clean water, safe infant feeding, and avoidance of breastfeeding. The Thai health system has made antenatal care free to all women who register for the PMTCT program before 12 weeks of pregnancy. Since 2007, The PMTCT program has been duly controlled by the Ministry of Public Health and the National Health Security Office. The Ministry of Public Health is in charge of leading policy and guideline development, training, monitoring, and evaluation of the program. The National Health Security Office aids in organizing the funding and aligning all lab-related activities, such as testing. Since August 2014, the program has incorporated an outreach component to diagnose HIV infection of newborns and promote early initiation of ART in those for whom PMTCT does not reach or is ineffective. This program includes training all relevant staff in PMTCT and immediate blood testing of infants at birth. These tests can be conducted at one of the 14 labs in Thailand that serve this purpose. Since the program's inception in 2000, a number of changes have occurred with the ART guidelines. When the program began, routine HIV testing and counseling was accompanied by short-course ZDV for the mother, ZDV syrup for infants, and the provision of infant formula. All of these parts still exist today, with the exception being that the drugs being recommended and used for treatment have changed. In 2001, some Thai sites began adding single-dose nevirapine, SD-NVP, to the regimen for both infants and mothers. This change was made part of the national guidelines in 2004. Between 2006 and 2010, CD4 count was considered when choosing what regimen to use in pregnant women needing ARVs. If CD4 counts were less than 200 cells per millimeter cubed of blood, women received NVP-based triple ART. If the count was above 200, then the regimen was ZDV-based with a single-dose NVP and 3 TC components postpartum. After more research, all women were recommended to use the regimen that has been used by women with CD4 counts lower than 200 cells per milliliter, regardless of CD4 count. In 2014, the guidelines were changed once more to have women use a regimen of TDF, 3TC, and EFV. Treatment should begin at time of HIV diagnosis, regardless of CD4 count or gestation of pregnancy. This was primarily done to eliminate the use of AZT and NVP from regimens, as there was a greater degree of side effects in the former and a higher propensity for drug resistance in the latter. The program sets goals regularly. By the end of 2016, the Thai PMTCT program seeks to have 98.8% of HIV-positive pregnant women receive ART to reduce mother-to-child transmission, have 90% of infants born to HIV-positive mothers receive a virological test for HIV within their first 2 months of life, have 60% of male partners of pregnant females be tested for HIV within the last 12 months, and to reach an annual MTCT rate below 2%. This rate is considered the elimination of MTCT in a nation and is indicated by the red dot in the graph on this slide. Rates of the listed goals are also shown on the slide for years they were collected. While all goals have showed progress in recent years, most will still need continued efforts to reach the proposed 2016 goals. Thailand's PMTCT program is based in a fair amount of policy. The National AIDS Strategic Plan 2014-16 is currently in place. It has a number of goals, with the elimination of MTCT as goal number 3. The elimination of MTCT is defined as a vertical transmission rate of lower than 2%. This strategic plan is written by the National AIDS Committee, or NAC, and is approved by the Cabinet of the Ministry of Public Health. Its current 2014-16 plan was written a few years ago and will be revised again for a newer version in the future. The current version of the plan devotes 4% of funds to strengthening the health and community systems. A second plan, entitled the Operational Plan, the latest version of which is 2015-19, elaborates on critical activities to ensure the long-term goal of the Thai Ministry of Public Health, ending HIV/AIDS in the country by 2030, is accomplished. Enacting these programs and their activities is by no means cheap. Thailand estimates that their current total domestic HIV expenditure in 2010 was $217.4 million US, an increase to $248 million in 2013. These domestic expenditures accounted for 85% of the total costs of HIV-related programming in Thailand in 2010 and 89% of it in 2013. The remaining percentage, 11% in 2013, is funded by outside agencies and organizations. The largest outside funder of Thailand's HIV-related programming is the Global Fund. Their funds primarily work to fund projects relating to the prevention of HIV in key populations. It should be noted that between 2010 and 2013, there was a 48% increase in spending on prevention-related HIV activities in Thailand. PMTCT is considered a prevention-related activity. Thailand primarily obtains the ARVs for its PMTCT program through two sources: domestic production, or imports of generics from nearby India. This is accomplished through compulsory licensing. As the supply chain is so dependent on local or nearby sources, travel times and costs of importation are less of a worry. This allows money to instead be put towards improving the programs and assuring a high quality of medications. For the Southeast Asian region, Thailand has a fairly sophisticated pharmacovigilance and regulatory system for pharmaceuticals. Thailand currently has a regulatory framework, a register for approved medical products, and requirements for licensed pharmaceutical premises and personnel. A portion of their Ministry of Health budget is dedicated to pharmacovigilance activities that align with their national pharmacovigilance guidelines, which are updated regularly. Their Medicines Safety Advisory Committee has regular meetings that address conflicts of interest with their medicines purchases. As a country, Thailand has a WHO pre-qualified quality control laboratory and is an official member of the WHO International Drug Monitoring Program. They have implemented standardized national adverse event forms for all health products. These forms collect data on suspected ADRs, product quality issues, medication errors, and treatment failures. There is also a mechanism in place for consumer reporting with active surveillance ongoing. Current estimates place the level of unregistered medications in the country at less than 1%. Ultimately, each of these strengths in pharmacovigilance helps the PMTCT program, as it ensures that the drugs either made or imported into Thailand are of a high quality for patients, reducing the number of treatment failures and adverse events. The PMTCT program measures its success through a number of variables. These include the rate of MTCT, the proportion of pregnant women not receiving any ART, the proportion of newborns of HIV-positive mothers receiving PCR testing in the first 2 months of life, and the coverage of couples testing, a way to increase uptake of male HIV testing and potential involvement in pregnancy. In order to obtain the goals set forth as stated previously, the program must be monitored and evaluated for efficacy. While some monitoring and evaluation is currently done, the newest 2014-16 strategic plan seeks to improve upon this through the following steps. 1. Hold meetings with the National Committee and regional health centers to develop a better system and handbook for use of M&E data concerning PMTCT. 2. Hold meetings of the task force for monitoring and evaluation to promote monitoring of progress, planning of the improved system, database maintenance, and applied use of the data. 3. Hold workshops for National Committee members, resource persons, and regional health centers with this improved system so that they can improve their own monitoring and evaluation at their sites and utilize the data better. 4. Inspect and feed data obtained back to managers and relevant others concerned with the program. And finally, to present these results to all relevant parties. While this will take a great deal of work and coordination, it is a necessary step in order to achieve the goals set forth by the National AIDS Committee concerning the PMTCT program. There are a number of stakeholders involved in this program, but two must be given special distinction for their key efforts to the program's success. UNAIDS, an endeavor of the United Nations to halt the spread of AIDS, helps Thailand's PMTCT program through its leadership experience, advocacy efforts, provision of information and technical support, the tracking of data, and its monitoring and evaluation programs. In fact, most information about Thailand's PMTCT program can be obtained through the detailed files created and held by UNAIDS. Another key stakeholder to the program is the Global Fund for AIDS, Tuberculosis, and Malaria, more commonly shortened to the Global Fund. Their aid to Thailand's PMTCT program is mostly financial. As of March 1, 2016, the fund has signed on to invest just over $341 million to Thailand in HIV/AIDS related funding since it began to provide aid for the country's programming in the early 2000s. The last grant specifically pertaining to the PMTCT program was from 2003 to 2009, entitled Enhancing HIV-Related Care and Treatment for HIV-Infected Mothers and Their Partners and Children. This grant provided Thailand with an extra $12.2 million in funding for its PMTCT-related programming. The Global Fund now is scaling back its HIV/AIDS funding in Thailand, as Thailand is almost entirely covering its costs domestically. Instead, the fund is giving more money to malaria and tuberculosis initiatives in the country. Thailand is making large steps forward to make their HIV/AIDS interventions, and especially their PMTCT program, even more wholly theirs in the upcoming future. As stated by the latest UNAIDS 2015 report, Thailand is focusing on preparing for the transition to full self-reliance to ensure sustainable domestic financing of the HIV response. Thailand is establishing, advocating, and accelerating leadership at the subnational level, including local administrative organizations, for a sense of local ownership and contributing budget to fund the HIV response in local areas. With plans to become fully independent with their HIV programming in the next coming years, Thailand is fully embracing country ownership of the program. Over the course of the PMTCT program's history, a number of challenges have been met and lessons have been learned. Other new challenges have also arisen. Over the course of the past 15 years since its inception, Thailand's PMTCT program has encountered a number of problems. These have included problems associated with scale-up, such as ensuring the increased amount of ARVs are procured, that they are of good quality, and that they are accessible to all members of the population at an affordable price, or free in almost all cases through the government. The inability of patients to afford hospital fees, especially at private hospitals, which may be the health center of choice by the patient. Problems associated with transportation, such as the cost of travel from a rural village to a larger city center to obtain medications. And problems associated with stigma, discrimination, and capacity. The problems associated with stigma and discrimination are common to almost all those who are diagnosed with HIV, including a fear of being blamed for contracting the virus, fear of being mistreated in the hospital, and fear of their status being disclosed. To those with HIV, privacy is paramount. Most problems associated with scale-up of the PMTCT program are related to a lack of capacity. This has largely included the lack of antenatal care to all Thai residents and thus subsequent delay of antenatal HIV testing. The next slide will discuss how many of these challenges were met. As stated, challenges arose during the scale-up of Thailand's PMTCT program to a national endeavor. Many of these challenges were met through the following means. First, the strengthening of public health infrastructure. Throughout the last decade, Thailand has made efforts to improve their public health system, making it easier for all citizens to obtain access to affordable public health care, including free antenatal care when registering before the 12th week of pregnancy. Thailand has also met scale-up challenges by improving their training for healthcare workers. This has involved workshops and initiatives in training for HIV counseling, clinical management, and program management for the various healthcare staff members involved at over 880 public hospitals in the country. One of the key points to improving any program is getting a community to invest and buy into it. This has been made possible in Thailand through mobilizing communities to support PMTCT by improving their knowledge and making the services more available to them locally. With more trained healthcare workers at these affordable public healthcare sites, more Thai residents have been able to be served by the PMTCT program. The program's leaders and other involved stakeholders have also focused on assuring that the recommended antiretroviral regimen for PMTCT is made available to all. This has involved using TRIPS flexibilities, such as compulsory licensing, to obtain the necessary regimens as generics, either made in-country or largely from India, and then distributing them throughout the many health centers offering PMTCT. Healthcare workers have had training on new regimens as necessary so that they can then inform patients about these changes. Finally, the wide-scale implementation of a registry system within the PMTCT program has drastically improved the organization and made it easier to track where the greatest efforts need to be spent in the coming future. As the program now moves into an elimination phase, this is even more vital to see where the small percentage of MTCT is still occurring in the country. Some overarching lessons that can be learned from the PMTCT program as a whole are the importance of strong government investment, country ownership, and community mobilization of programs. Without these components, the program's success would likely not be anywhere close to what it is today. Thailand has also worked to normalize both sex and the HIV virus, making strides to combating stigma and making it easier for patients to live their lives. Both of these large-scale lessons are vital to the PMTCT program's success, as they have enabled medications to be made available to even more women during pregnancy and encourage these women to follow their regimens for the health of themselves and their future offspring without fear of being judged by those around them. Thailand's PMTCT program still has challenges to face moving forward. In 2014, the level of couples counseling, a key way to get both partners tied into the health system and on antiretrovirals if need be, remained low, with only 42% of couples coming in for antenatal care receiving HCT. These remain a small but significant number of women in Thailand who are still not registered for antenatal care, meaning they're not being tested for HIV or being given ARVs if they need them. Migrant women, or women living in Thailand who are not Thai citizens, still lack services in many cases as they may pay out of pocket for the testing, medications, and care. This is especially relevant in the wake of natural disasters that can move a population of women into the country from other Southeast Asian nations, such as Bhutan. When women are found to be HIV positive, 40% of them do not return to their delivery facilities for postpartum care and follow-up. At the moment, the data from the PMTCT program is only compiled from public sources. National rates could thus be higher of MTCT than the data suggests, as data from private hospitals is not included at this time. A final challenge to the PMTCT program in Thailand is the continual changing of ART guidelines. The World Health Organization has made minor changes with these every few years or so, since their inception, due to better knowledge of side effects and drug resistance. As Thailand seeks to offer the best recommended ARV regimen to its citizens, the changing of guidelines means a lot of work must be done in multiple government sectors. A sound action plan for another guidelines change is needed. To meet these challenges going forward, Thailand has come up with 3 major aims in their latest strategic plan. Aim 1 is to review current PMTCT data and see where the greatest gaps in coverage are. From this information, they will be able to target those specific regions, clinics, or health centers as a priority for PMTCT programming, while also assuring that other nations maintain their similar rates of care and access. Aim 2 relates to increasing the availability of PMTCT to migrant women. This will be done through increasing insurance coverage of migrants so that pregnant non-Thai citizens and their future newborns can receive equal and quality access to HCT, ARVs, and care. The third and final aim of the plan going forward with PMTCT is a number of smaller pieces related to data monitoring. To monitor and conduct reviews on the latest policy changes to see their effectiveness, to continually analyze the coverage and retention into the ART system of HIV-positive pregnant women, and to identify obstacles to couples counseling. With work, each of these manageable aims can be accomplished. Finding inspiration. I seek to be a pediatrician, so when choosing a topic for this case study, I wanted to look at an issue pertaining to children's health. PMTCT not only enables children to have a lowered chance of becoming infected with HIV, but also prolongs the lives of their infected mothers, keeping the children from becoming orphaned at a young age. Thailand's case especially appealed to me because it's a success story, whereas the area my practicum project focuses on, sub-Saharan Africa, specifically Durban, South Africa, still struggles with MTCT and a continually spreading epidemic, leaving thousands of children infected, orphaned, or potentially both. I found the government commitment to the program to be particularly inspiring, as I've learned throughout this program about the importance of getting a strong foundation of support and local ownership in order for any health-related system or initiative to have greatest success. Specifically from this course, I've gained a much better understanding of how complex the process of getting access to medicines is around the world. Thailand's PMTCT program is an example of how many components can come together, specifically within their own government, starting, for example, with the Ministry of Health, then reaching to such sectors pertaining to trade, taxation, and migration, in order to streamline this process and then provide high-quality ARVs to their citizens. They've not been afraid to utilize TRIPS flexibilities in order to make ARVs available for their citizens. They've engaged with outside donors in order to start new innovative projects. They continually seek to find new ways to reach the key populations who still see rates of HIV that are not in decline. I would hope that in the future, more low and middle income countries can look to Thailand's PMTCT program as an example of what good can occur, with a strong base in the country, a starting amount of seed money from donors, and then a transition over time to complete domestic ownership of a strong program that's continually monitored, reviewed, and adapted. Thank you for listening. Here is a compiled list of references. They can also be found individually on each slide.